was saying before, the challenge in AI, I think, is less in how to treat COVID patients, but more in how to keep the non-COVID patients safe in this turmoil and change in practices and workflows, which basically change the way that we treat the non-COVID patients, because these are kept out of the hospital. Maybe I'll start with a use case that happened a few years ago here of a 9-year-old boy that went to his primary care physician, and he wanted to prescribe the boy with Singular for asthma, but by mistake, he clicked on the next entry in the pooled menu list, which was Syntrom or warfarin, a very potent anticoagulant. And the prescription was fine. It was just the wrong patient. And even though he entered it into the electronic medical record system, signed on the prescription, the mother went to the pharmacy, took the medication, and the boy died 7 days later after falling from his bike and hitting his head from intracranial hemorrhage. Now, looking at this catastrophe, it wasn't bad judgment on part of the physician. It was a slip-up, like killing someone with a typo. And one would have thought would be some kind of a cool spell checker to prevent this from happening, but this is not the case. Looking from 30,000 feet into the workflows that may lead from prescription to dispensing to the patient actually receiving the meds, there are many stations down the line that have all the relevant information about the patient and about the medication, but all of them have failed in this specific case to identify that this was just the wrong drug for the wrong patient. And this really made us understand that although it was a failure of an individual to click on the wrong medication, it really represented this a failure of system, because such a systematic failure with so many parts may need a systemic solution. And looking at another dimension of the process, we see that most systems that are currently deployed in healthcare systems, trying to identify medication-related risk, is mostly focused at the prescribing event and at the dispensing event. But most of the catastrophes and patient harm is caused way after the patients are home, when they are completely uncovered by the systems to date because of adverse drug events or contraindications or any change in their clinical status that may render one of their active medications suddenly dangerous to them. And taking all of this really highlights the importance of some kind of a systemic safety net to provide clinicians and workflows from causing harm to the patients. And when we look at the current technologies out there to date, most of them are rule-based systems, drug interaction databases, allergy checkers, and these systems have several flaws. Mainly, they cover only a predefined list of potential errors, where many of the errors, like the one that killed the boy, are random effects of random clicks or things like that are very hard to anticipate by any rule-based system. The other other problem with rule-based systems is that in most cases, they are not personalized to the specific properties of the patient. If you can mute, it will be very easy, because currently there's a lot of noise from one of the people here. And because these alerts are not, systems are not personalized, they cause a high alert burden. 10, 20, 30% of all medications are flagged by these systems. 90+% of these alerts are false alarms. And this drives into what is called alert fatigue, in which physicians are overburdened by the alerts and basically ignore all of them. So at the end of the day, even if there's a safety net in place, it doesn't catch much, and many patients are harmed. Now, extrapolating this into the COVID era, where many of the encounters, 40% of the encounters with physicians currently in the US are not face-to-face, but by telephone or telehealth, it provides a much bigger opportunity for harm to happen, and hence the need for some more systemic solutions to catch these risks and identify them and prevent them before harm actually happens. So the way that we approach this problem, identifying that rule-based systems are probably not good enough for this, is applying methodologies that come from different industries, from credit card fraud, from finance, from aviation, and mostly applying sophisticated algorithms on large-scale data and identify outlier behavior as potential risk. And this could be anywhere from prescription errors, opioid dependency risk, which is a huge problem in the US right now, identifying evolving adverse drug events, contraindications, gaps in care, changes in trends in labs and vitals that may be the first clue of something happening to the patient. But in order for this to happen, we need to learn from the failures of other systems, mainly focusing on providing very, very low alert burden, very high clinical accuracy and relevance, and that they will be actionable at the point of care. Because if I think about my resident at 2 o'clock in the morning at the hospital, he didn't sleep, and he has 15 patients waiting in line. For each of them, he has to prescribe between 10 and 30 medications. If we flag 10 or 20% of them, we just ignore the system altogether. So this was basically the challenge that we were facing. And for that, we needed to do some development of infrastructure that was not available at the time. Mainly taking raw, unstructured data from the EMR, the electronic medical records, and applying on them very rigid methodologies of cleaning, coding, normalization, so they will be ready for the application of sophisticated algorithms. And then applying the algorithms on top of them and going into back and forth with clinical leadership in the hospital and in our team to make sure that the outliers that are found actually represent risk and not just a deviation in practice. And just to give you a sense of how that might work, so looking at that 9-year-old boy that by mistake received the warfarin, if we look at similar patients in similar clinical scenarios, and we take the 1,200 medications in the list of the HMO and sort them by the likelihood of them being the next medication to be provided to this patient. So upfront would be maybe Tylenol and maybe some amoxicillin for a sore throat and maybe a vaccination of some sort. But at the end of the line would be maybe birth control pills, anticoagulation, and chemotherapy. They are the least expected for this patient to have, because and just by that, we already can identify that this patient is very unlikely to receive anticoagulation and may provide a warning on that. But this is not enough, because for some kids, they may have prescriptions for warfarin that are good for them. So for that, we will need to look at the dimension of the medication itself and look, what are the properties of patients that are likely to receive these medications? Obviously, most of them are elderly, but they may have diagnosis of some kind of cardiovascular disease, hyperthrombotic state, atrial fibrillation, pulmonary emboli, and any other diagnosis. Maybe they visited a specialty clinic, maybe had an INR tested, or maybe had co-medications that provide us with clues and hints that they are likely to receive anticoagulation, such as antiarrhythmic medications of some sort. But in this case, again, it wasn't the case. And lastly, what is the nature of the normal prescribing patterns of that specific individual prescriber? So if he's a pediatrician in a GP clinic, the likelihood of him prescribing anticoagulation is extremely low. So on combining these three dimensions together, automatically we understand that probably this is the wrong drug for the wrong patient, and would prop up an alert at the provider to say, hey, are you sure you want to do that? And this is the only intervention that we will do. And examples of things that we have found include chemotherapy to a healthy young mother. And this kind of connects to the previous discussion, because this was a 23-year-old woman with lupus. Her chronic medication was hydroxychloroquine, the drug that we discussed before. But when she went into labor and came to a C-section at the hospital, the gynecologist at ward didn't sleep for 2 days, and instead of hydroxychloroquine, prescribed her with hydroxyurea, which is the oral chemotherapy, obviously not the drug of choice for that specific mother at that time. Obviously, it's lucky that we have prevented that. Another example is an example of monitoring events. Prescriptions that were perfectly okay at the moment of prescribing, but something happened later on that rendered them suddenly dangerous to that patient. For example, a 50-year-old male with cardiovascular disease treated since his last myocardial infarction with aspirin, but 3 months ago was diagnosed with diffuse large B-cell lymphoma, treated with R-CHOP, and 3 weeks later has severe thrombocytopenia. And at that time, the aspirin that he was taking, rightfully so, only a week ago, suddenly became dangerous. And there was a disconnect between the cardiologist who prescribed the aspirin and the hematologist that provided the chemotherapy. And we were able to bridge the gap and provide the alert to both and say, hey, we have a risk here. On one hand, it's aspirin from one physician, the chemotherapy from the other, but the end result is a real risk for the patient down the line that we can identify and prevent. So the first thing that we did is go and find the right people in the academic community that dealt with these type of problems. And we encountered with Dr. David Bates, Chief Quality Officer at the Brigham and Women's Hospital. And we've been partnering with his research group for some years now, and 2 publications came out, another in the works, and another publication from our partners in Sheba Medical Center, a prospective pilot. And really the results of these academic studies and live deployments in multiple hospitals in Israel and in the US shows that more than 80% of the interventions that we provide have clinical value. That means that physicians actually pay attention to them. 70% are unique to us, and most of them are of the monitoring phase, post-dispensing, post-encounter, and these are the interventions that are currently missed by those systems when these patients are at home. The alert burden is very, very low. 1 in 200 prescriptions for inpatients, 1 in 1,000 for outpatients. And the response rate of physician causes most of them to change their behavior within minutes following the alerts that we provided. Just to give you some insights into the numbers that we are dealing with, every day in just 4 specific sites, we analyze tens and hundreds of thousands of elements and new prescriptions and almost 500,000 old prescriptions and encounters and admissions. And out of this, only 250 alerts, a very, very low alert burden. And most of them are clinically relevant and cause a change in physician practice. Now, it's very, very small numbers, but they translate into very large numbers at scale. Annually, almost 80,000 interventions, and each of them have either prevented an adverse drug event, a contraindication, or different kind of risk for these patients. And just examples of the stuff that we monitor: patients on beta blockers that suddenly develop bradycardia, patients on antihypertensive medications that develop hypotension, and really any distant connection between lab vitals and medication that we monitor continuously. Another thing that we know how to do is identify personal outliers in lab results. For example, if I had hemoglobin levels of between 15 and 16 chronically, and suddenly I have 13.8, it's still within the normal range, but for me, it's a personal outlier and may necessitate and raise a red flag that, hey, something is going on. Maybe I have some anemia that is brewing, maybe a vitamin deficiency or intestinal bleeding, or maybe a hematological disorder, but definitely something that to look into. This is something that is very easily missed by primary care physicians because it's still within the normal range, but maybe the first early sign of something deteriorating. And it's not only hemoglobin, it could be creatinine, other electrolytes, etc., etc. And really our claim to fame is really identifying the wrong drugs to the wrong patients. These very rare events, but mostly catastrophic. I think one of the most appalling ones is a 1.5-year-old baby admitted in the hospital for influenza, and instead of Tamiflu for influenza, he was prescribed with tamoxifen, tamoxifen, obviously not the drug of choice for a 1.5-year-old baby. Another patient mixed between Keppra, which is anticonvulsant, with Keplex with antibiotics, and methotrexate to an 8-month-old baby completely by mistake. And another case of EMR-derived errors when the physician just prescribed the right drug, but for the wrong patient, which is very easily done in EMRs. When a 50-year-old hospitalized with pneumonia without any cardiac problem was prescribed with digoxin without any indication by mistake. Obviously, again, not the right drug of choice. We have partners and customers in Israel and growing into the US. And I'll finish by a statement that, as a physician, I went into this journey to make sure that patients are really not harmed by silly mistake, by typos of clinicians. And I think that in the last few years, we've been able to demonstrate that A, we've been able to do this, and B, there is an opportunity for the combination of clinical knowledge and AI in promoting patient safety at scale. And for us, it's only the beginning. Thank you very much.
Thank you. Thank you so much, Gidi. You know how much enthusiastic I am about your solution. And I'm just asking myself when it will be the standard of care that everywhere we will have this kind of solution. It's like, I don't understand why it's not already available for everybody. It's saving life, but it's also saving money. So when do you think that it will be the standard of care that we will not be able to avoid this kind of solution?
I think it's getting there. I think there was, in the last 10, 15 years, an evolution that started with the promise that electronic medical records will make patients safer. And there was a whole wave in the US and started by President Obama in applying electronic medical records throughout the hospitals. And then they saw that it maybe changed the financials of the hospitals, but it didn't really provide any benefit in terms of patient safety. So this was a disillusionment, and not only that there was new types of catastrophic errors that resulted because of the fact that they were using electronic medical records, and it was not applicable when we wrote manual prescribing. So the next phase was, okay, let's take the technologies that were developed by pharmacists at the pharmacy and apply them to the medical records to try to identify risk. The first, or one of the first, was the first data bank, which was like a manuscript, a monthly manuscript for pharmacists that was bought for $60,000 by Hearst 20, 30 years ago. It's now an operation that covers 60% of the market and has $200 million in revenues every year. And what they do is basically drug-drug interaction, allergy, dosage, fixed rules. And they thought, well, maybe this will fix the problem of patient safety. And even though it was regulated and reimbursed and in the US, but in the last few years, it came to the understanding that this doesn't do good. Although the systems are in place, physicians ignore them. There's a lot of talk about physician burnout, alert fatigue, and these systems are basically ignored. And I think now is the time to think of other opportunities. And I think a solution such as ours is an obvious next step. AI was operational only, I think, in the last 5 years. There are not many AI operational systems in hospitals to date. There is some systems that are in the imaging world, which is more advanced in that case. But in understanding electronic medical records, it's still in the early phase. And I think we are one of the first that have done that. So as being first, it always takes longer to educate the client that this is what they need. But I'm quite encouraged by our clients who basically like what we're doing. We measure their response, and they're very big advocates of what we do to other clients, which is good.
So do we.
Thank you.
So Gidi, are you with us? Just unmute your microphone.
Do you hear me?
Yes, we hear you. We don't see you, but we hear you.
Okay, I did something wrong. Anyway, I think it's about time for us to wrap up. I think with all the technical issues we had and we survived them, it's a good sign that the next meeting in September of COVID drug will be amazing too. And I want to thank, first of all, yourself, Irina, for taking all this effort, and for, of course, our amazing speakers and people from different countries that join us. Have a safe evening, and let's all keep ourselves healthy.
Okay, I have just two slides to show to you, and we will be done. First of all, I want to thank everybody. Do you see my slide?
Yes, Mr.
Okay, I have just two slides, just to tell everybody thank you so much. We are very proud to have Gidi Stein, Gidi Cohen, Peter Peace, who are a member of our scientific committee, people from steering committee. Yudit, thank you so much. And
thank me. Tomorrow maybe, but today I have to apologize to all the attendees that we made some big mistakes, but we tried our best, and next time it will be better. So
okay, hopefully. So thank you to the two newcomers, Joel Inovloki and Dorothée Chekron, who have helped me so much. I just wanted to remind you that we still have three more events this hot summer, and that will be tell us a safety case story, and then we will come back in September with a second summit on drug safety in the COVID era. We will have tell us a safety case story every 2 weeks, one in Hebrew and one in English. We will have a collaboration with the chapters in North America, Latin America, and Switzerland, and we will organize also many workshops. So stay with us and become members. Come to speak about your cases, and thank you so much for attending, and sorry for the technical problem, but it seems that you have survived. Thank you so much. Have a nice evening.
Thank you.
I'm closing the meeting.